was going to make one correction.
Please.
There were some minor things, but on page 50 and 51, line 25 on page 50 and line 2 on 51, I think the word intravenous was meant to be something else. I think schizophrenia is a substantive difference. The rest of them were all minor stuff.
Sorry, on page
50 and 51?
Oh, intravenous.
Right.
I see.
I think if you look back at the
Okay.
document, it's
Yes, thank you.
and it's the same thing on the next page. There's 2 in a row.
Yes. Noted. Mr. Merrill, you want to make those corrections?
Yes, we will.
And with those, with that correction, are there any further comments on the minutes from the board? So now, can we have a motion to approve the minutes with corrections? Second. We have a motion, can we? Good. Seconded by Dr. Richardson. Can we then approve them?
Aye. Aye.
Aye. Thank you very much. So we now turn to a notice of adoption on a resolution to amend Article 175, radiation control, that will update the quality assurance requirements for external beam and brachytherapy radiation treatment to promote a safer and more effective treatment dose. I believe we have a short presentation from Christopher Boyd. Good morning, Mr. Boyd.
Good morning. I am Chris Boyd. I'm the Assistant Commissioner for Environmental Sciences and Engineering. I'm going to give you a quick recap of the proposed changes that we're asking you to adopt today. Just for a refresher, the New York State Department of Health updated its quality assurance requirements for external beam and brachytherapy. We need to be as least as stringent as the state in order to maintain our local responsibilities. We've got about 100 facilities that are going to be impacted by the proposed changes. We received no public comment to the proposed changes. Just a quick reminder of what these changes will do. Board-certified radiation oncologist or other qualified physician must supervise patient care. Radiation oncology accreditation by American College of Radiology, American College of Radiation Oncology, or another organization acceptable to the department. We hear that there are a couple other organizations that might bring together a package to provide more options for providers. Clinical staff have a proactive requirement to act if any aspect of the treatment plan is clear or erroneous. Unintended deviations from the treatment plan requires evaluation of the cause, actions taken. Those need to be documented so we can review those when we do our inspections. And then high radiation doses need to be verified independently. So there's a threshold in the requirement. If you go above that threshold, there needs to be proactive secondary check to make sure that that goes to the appropriate. And those are the changes. And with that, we would ask that the board approve for adoption.
Turn now to the board for any questions or comments. Then we have a motion to adopt. So moved.
Second.
All in favor?
Aye.
All right, so we're now going to have a couple of presentations that are relevant to the upcoming presentations for notices for publication. The first will be on syndromic surveillance. Are we ready with that presentation? So these are informational presentations.
Hi, good morning, everyone. I'm Rob Mathis. I'm Director of Syndromic Surveillance Unit in the Bureau of Communicable Disease. And we thought this would be a good opportunity just to give you an overview of syndromic surveillance in general, as well as how we actually use it in New York City, given that we're asking the board to consider language adopting pharmacy surveillance as part of the health code. So I'll just give a very brief overview of it's broken down into two parts. The first part I'll just give a very brief overview of syndromic surveillance in general, some of the context in which it's used, and then go into more specifically about the systems that we use in New York City, as well as some situations where we found it to be incredibly useful. So there are a number of different systems for monitoring and detecting disease outbreaks. And probably the primary system that most people think of when they think of detecting disease outbreaks is reports based on kind of these traditional systems. These include provider reports such as diagnoses from physicians, or laboratory reports where a patient is tested in a laboratory, and then the results of that laboratory report are then sent to the Department of Health. One of the newest systems that we recently implemented is monitoring social media for foodborne illness, where our foodborne illness group is looking at a social media website called Yelp, consumer restaurant reviews, and they're able to pick out different words and text strings and these reviews that people like us are just writing about restaurants, looking for indicators of foodborne related illness or food poisoning or things like that. And then the third system is what I'll talk about over the next 10 or 15 minutes, syndromic surveillance. So what is it? Syndromic surveillance is a system that uses routine, pre-existing, non-diagnostic data, such as emergency department chief complaint or a medication sale. And an example of an ED chief complaint might be someone coming in complaining of fever and cough, or it could be a sale of some Imodium HG at a pharmacy.
Excuse me, sir, would you mind speaking up a little bit and slower?
Okay.
Or maybe into the microphone.
And so what we do with this data is we categorize these different healthcare encounters into syndromes. So for example, fever and cough would be categorized into a kind of a broader syndrome such as influenza-like illness. And then we look for patterns in the data. And we look for patterns by age, by geography. So we typically get residential zip code for EMS and emergency department data, and zip code for also pharmacy locations. And then of course look for patterns by syndrome. And this allows us to compare these patterns to what we would expect to see. So we've developed these statistical models to create kind of expected values of, say, for example, vomit syndrome based on the time of year and the day of week. We can also compare patterns to previous years. So for example, we know that influenza season strikes every year, but it's at different times of the year, and so we can look to see how this year's influenza season compares to previous years, both in terms of timeliness and magnitude. And then of course we do get zip code data, so we can compare patterns within the city either by zip code or by neighborhood. So what's the downside of syndromic surveillance? Well, it doesn't tell us if a person actually has a disease, given that we do not get any information on laboratory data or medical diagnosis, and therefore it doesn't replace traditional disease surveillance. So what is it good for? Well, I'll give you a really good example of why the utility of syndromic surveillance can be really good. So if you think back to 1993, the cryptosporidium outbreak in Milwaukee, there was a failure at a water plant there. Cryptosporidium leaked into the public water supply, and a lot of people got sick, and many people died. And one of the few systems that could have picked this up would have been a pharmacy surveillance system. So retrospective analyses showed that pharmacies had a threefold increase in anti-diarrheal sales in March, and a lot of this was happening in the latter part of March. And kind of the take-home message was that public health wasn't notified until early April. And the system that we currently have in New York City monitoring pharmacy sales would have picked this up much earlier, and therefore letting public health be aware of this much sooner than they were in Milwaukee. Syndromic surveillance data is electronic, which is great for us because it's incredibly easy to analyze and it's timely. We get data in currently near real time, which is in the previous 24 hours, and that's moving towards essentially real time. So we're starting to get data from certain hospitals As electronic health records are updated, we get instantaneous messages with that updated information. It could be an ICD-9 or ICD-10 diagnosis code or something else. Secondly, is laboratory confirmed cases only represent the tip of the iceberg. Not everyone who goes into the hospital gets tested for a particular disease. We have an incredible amount of baseline data. We started collecting this data in 2001. And so we know current trends, we can compare them to previous years, and we can know what to expect. It's really great for monitoring trends of both communicable disease as well as non-communicable disease. And then finally, we look for a number of predefined syndromes, but sometimes it's more interesting to look for the unknown and the unexpected, and we have ways in which we can do that. And then finally, just to give you some context of how syndromic surveillance is used. The first thing that you probably can think of is just outbreak and event detection. So looking for clusters or spikes in visits, and this is kind of the biggest rationale for developing the system following the 2001 terrorist attacks, looking for biological and biochemical terrorist activity. Recently, the system has been heavily relied upon during these emergency events, using it for what we call situational awareness. These are things using it for during the pandemic H1N1 or Sandy. And then third and fourth, just the use of it for identification and monitoring of expected seasonal trends such as influenza or asthma, or changing or emergent trends. So we'll be comparing hospital utilization currently to past years and seeing how that's changing. All right, so this is just a thumbnail sketch of how syndromic surveillance is used in general. And now we'll go into specifically about the systems that we use here in New York City, as well as some specific examples of when it's been useful. There are 5 systems currently in use. These include emergency department visits, over-the-counter and prescription pharmacy sales, EMS 911 calls, and school nurse visits. In the middle column showing the mean daily volume is just to give you an indication of on any given day this past year how many patient encounters we would expect to see. So for emergency department visits on any day, we typically see about 1,000 unique visits. And so we conduct this analysis every day, and we bin all the data into these predefined syndromes, and we look for clusters of disease. And this is just one of the reports. This is from our ED system, just showing you what the analyst sees. We're looking at a number of different syndromes, both long-term and short-term trends, and a signal report on this day. Back in February, there were no signals, but if there was a signal, we would have a signal report, and then just some data quality measures about hospitals reporting or not reporting. All right, so how has it been useful? So we think back to 2003. So one of the first, actually the first example I'll show is regarding outbreak detection. And if you think back to 2003, the blackout that occurred in New York City, where many of us lost power. And here at the health department, we anticipated an increase in diarrheal sales, and this was something that we were in our systems for. And subsequently, we sent out reports to the public, urging them to discard any unrefrigerated food, but not everyone heeds those reports. So we monitored our systems anyway, and lo and behold, we saw signals in both our anti-diarrheal pharmacy surveillance system, which is the top graph, and you can see that signal circle there at the top, as well as our emergency department system, which is the bottom graph, showing that sudden spike in emergency department diarrhea-related visits. And just the take-home message with this is that there was no other systems out there to detect this diarrheal increase. There was no increase in enteric reportable disease, and so really the syndromic system was heavily relied upon during this event. And I'll just give you now just 2 examples of how the systems have been used during these emergencies. And as I mentioned earlier, the system has been relied upon incredibly heavily during the most recent 3 or 4 events that we have. It seems like almost every year there's an emergency event that New York City is facing. This is just a picture of flooding that was occurring in Manhattan during Sandy. The first example I'll give is from the pandemic influenza in 2009. And the system was really good for tracking the of the outbreak, certainly by age group and by magnitude. And so the top graph that you see is the tracking of the rate of ILI, emergency department related visits by 4 age groups. And just the thing to note here is just the really sharp increases in ILI related emergency department visits in the youngest age groups, the 0 to 4 and the 5 to 17. That's the yellow and the red line. And not a whole lot of activity in the older age groups. The system was also good for tracking severity of illness. We don't get a severity index score or anything like that, but what we do get is whether or not a patient was admitted to the hospital. And so we can actually use that information to, as a proxy for severity, to track how many ILI cases were admitted to the hospital. And then the second example is from Sandy. And the system was really useful, especially in informing the Commissioner of Health, City Hall, and OEM about kind of what was going on really during Sandy. And so the top graph is just trends in respiratory-related visits. The solid blue line is citywide, which doesn't show a whole lot of activity, but we were interested in looking at those affected areas. And those areas are defined as either they lost power or were affected by the storm surge. And these included Staten Island, the Rockaways, and Coney Island. And you can see the sharp increase during Sandy and the subsequent decline after Sandy. The second, one of the other uses it was really good for was just identification of what we would call basic needs. And so the bottom graph is showing emergency department visits for things like needing methadone, a refill of an oxygen tank, or needing oxygen treatment, emergency dialysis treatment, or just simple getting their prescription medications refilled. And as you can see, before Sandy, it's generally less than 1% of all ED visits are for these particular needs. And then during Sandy, you can see the really sharp sudden spike for people. Just really, I think it's probably because their local clinics were closer, or where they were to get this their basic medication needs, they were forced to turn to the emergency department. And then the last big example I'll give is just the timely identifications of expected trends. And so this is a picture of bees pollinating in Central Park, and you can probably tell where I'm going with this. That pollen season is right around the corner. And this is something we work closely with environmental surveillance and policy on monitoring asthma-related ED visits and allergy or TC sales. And so the top graph that you see is our asthma-related emergency department visits. It's actually the second panel down from the top. And you can see the first spike in 2012, which looked like occurred in about mid-April. And then, let's see if I can have a cursor. Yeah, and then this spike here in 2013, which looks to be a little bit later and not quite as severe. And we look at this in parallel with OTC allergy medication sales. And we can see an increase starting in about late April. And OTC sales for this generally precede emergency department visits by a few days, because people tend to kind of self-medicate before seeking more emergency care. And this is really great during pollen season. Environmental surveillance policy does a really good job of just putting out notifications to the public that these types of medication sales are starting to increase, and just notifying people who suffer from allergies and asthma to seek appropriate care. And then I'll just end with just some really quick examples about how the data is used kind of for more non-communicable purposes. So the first example is just we monitored heat-related illness every summer. We track temperature, heat-related ED visits, and 911 calls. And this is just one of the graphs that's sent out daily. And these have been really useful during heat waves, which occur quite often in the summer, and they've been really useful during heat emergencies. And the Heat Emergency Steering Committee calls are implemented as other agencies are just interested to hear what's going on, certainly in the emergency departments and how many people are falling ill. The second example is monitoring drug-related visits. And this is just a very simple email that we sent out on a daily basis looking at various drug-related visits, such as alcohol, cocaine, heroin, things like that, what we saw the previous day and what we expected to see. example I'll show is just monitoring carbon monoxide related visits. We're particularly interested in this in the winter months, is generally when we see most of this activity, and we just look at a simple time series graph. And because we generally don't see a whole lot of people coming into the emergency department for this, we also look at a line list. And so here's an example of just a cluster of 4 cases. This is generally what we see. Our clusters is usually a family. They brought in, a heater or something to the apartment during the cold months, and that's when we kind of get into trouble. And then we see a family of 4 or 5 coming in, all within a span of, this cluster was in a span of about 20 minutes or so. And these are just 3 uses of literally dozens that can be used to tap kind of into this really rich syndromic data set. And just, I think the take-home message from this is that it really helps us keep kind of finger on the pulse of the city's health. And I will just end with this really fantastic picture of Mulberry Street that was taken back in 1900.
Very nice. Very
Thank
nice.
you, very nice, Rob. That was Rob Masses, I hope he slowed down enough for you. And so we're now open. I think there are going to be some questions.
You talked about the 5 data sets that you now employ to monitor these things. And this is fantastic stuff. Do you have your eyes on your next year's budget request ever for additional data sets that might further reinforce this monitoring capability?
I think I'll refer your question to our Director of Surveillance, Don Weiss.
Well, this is a good opportunity to put my plug in, that all these positions in this unit are grant funded. There's not a single position that is funded by the city. So we have put in requests for city funding. We have not yet secured them, but we'll keep trying. And we're always looking for new data sources that might augment this.
Any other questions?
Hi, thank you. Can you give us a sense what the lag time is with some of the newer sources of data in the system, like pharmacy sales? How long does it take for you to get and analyze and detect trends or patterns?
So we received data from the previous 24 hours. So the data that we received at around 8 o'clock this morning is from Monday, from midnight on Monday to 11:59 p.m. Monday night. And we analyze the data essentially as soon as it comes in. So our morning analysis starts around 9:30 in the morning. And just a follow-up to that, the hospitals are starting to move towards what we're calling meaningful use compliant data, which is essentially real time, which they're sending, as I mentioned, kind of updated electronic health record information instantaneously. We're getting that data literally within seconds as the health records are updated. And that's kind of what we're moving towards.
And then, of course, I can't resist the follow-up question. The schools, so since that is the most information you seem to get on a regular basis, all of the schools are sort of set up to communicate this information? Is it a lot by manually? Like, how does it work?
In terms of how the data is sent to us?
Yeah.
Yeah, the data sent to us is electronically, so it's their IT department has set up kind of an automated process in which they collect all the data from the schools and then sent it to us at the same time every morning.
Centrally then?
Yeah, I should say that we only collect data from New York City public schools.
Yeah, right.
Just to clarify, the schools do have at least, as far as I know, something known as the Automated School Health Record, or ASHR.
Yeah, that's right.
And these data come from
Yeah.
that.
Okay.
There's another question?
Question.
2 questions.
I want to thank you, Mr. Mathis. Are all these data sets available for scholarly use outside of the Department of Health?
That's a great question. Yeah, and they're not. We do have data use agreements with the hospitals, and that we wouldn't share hospital level information with outside researchers. We do occasionally get requests from professors at universities who want to use this data, and we do provide data to them that's been de-identified. Okay. So stripping out essentially zip code and hospital level information.
I just want to say I'm glad you are doing that, because the information you're collecting is incredibly rich, And to have that information available in a de-identified fashion, I think would further the cause of public health in general.
Oh, and Marcy just reminded me to mention EpiQuery. That's the electronic system that's here at the health department where outside researchers can actually access this data. And so this year, starting probably sometime in the summer, we're going to be uploading syndromic data to EpiQuery so people can actually look at various trends and actually download data. Again, that data will be de-identified, and we'll start with emergency department visits.
And one last question, thank you.
You mentioned the meaningful use, only the hospital or also the clinician working in the communities that are using electronic medical record and complying with the meaningful use of diarrhea, asthma, etc.
Yeah, both. But as far as the syndromic unit is concerned, we're only going to be collecting data from hospitals. It's PCIP will be collecting meaningful use data from providers and other clinicians.
And I overlooked Dr. Foreman.
Sorry, thank you. It was a fascinating presentation. I had a quick question about the responses that might be possible with the use of this, I guess, what would be considered big data. You mentioned that prescription data about allergy medications jumps up before ED visits jump up. And I'm wondering if any institutions use that data to adjust their staffing in advance. From my end, at the hospital where I work, you know, it's sometimes unpredictable, but that was sort of suggestive and looked consistent that, you know, if you really get a spike first and you know in the next 24 to 48 hours you're likely to get a lot more patients. Is that provided back? Has anyone tried anything like that?
You know, I would say it's probably not more than the people in the emergency departments can do for themselves. I mean, really, sort of empirically. Do you know what I'm saying? It's an interesting idea, but I don't think that that would probably be
Dr. Richardson wants to come in on this.
Well, the answer is it used in this way? No. I think that there's a certain amount of slack and reserve that's built into emergency department staffing, and we are aware of these seasonal variations, although the timing of things like pandemic flu and so on does vary year to year. But it's an interesting notion.
Yeah.
I think operationally it would be very difficult to implement.
My naivete. Sorry.
I have one question for you, Mr. Mathis. You've shown us very nicely how many sources that you draw on to show these peaks, particularly the importance of pharmacy data, which we'll be turning to later. But you didn't mention the school data, and I wonder how often do you notice these peaks sort of reflecting through the various sources, like over-the-counter to ED visits to hospitalizations, and say a little bit about the school data?
Yeah, that's a really great question. There are no. Right now, we don't have any statistical methods to pull in all the data sets and compute some sort of statistical value based on what we're seeing in all 5 systems at once. But the analyst does look at every system in parallel every morning. And just, for example, we're starting to see just a little bump in ILI school visits, and just one of our regular reports from the previous week, we were getting an increase in flu B laboratory data, which is sort of reflected in what we're seeing in the school. So that is something that we certainly take into account.
Great.
And I also just wanted to follow up with Joel's question. So just 2 quick things. First of which, we do send out health alerts when we do start to see increases in, for example, allergy medication sales or asthma-related ED visits, and that's something that environmental surveillance and policy does a great job with. And the second thing to note is that we visited every single emergency department about 2 years ago, so about 50 emergency departments in the city. All of our analysts went out and we talked to the ED directors about specifically how their systems work and what they would like from us. And one of the comments was that they would really like to see feedback on their own data because they're just too busy to actually look at and analyze their own data. And so we've been developing these sort of analytic reports that we'll send out either quarterly or monthly. We haven't quite decided yet to all the ED directors, just showing them different patterns in their data and kind of how visits change by hour, how they change by day of week, and so on.
One quick comment with the school health records. You ought to track in parallel if you're not already doing it. absentee rates, because the problem with that data is it's only the kids who are in school who get the medical reports.
Yeah, actually, I wish I put that in, but yeah, we do get absentee data
You
as
get
well.
the
Yeah, and we look at it in parallel with the school data.
Great, thank you very much. So we now turn to our next presentation, which will be about the health information exchange, and Dr. Parsons. Welcome.
Good morning, everyone. I'll be speaking to you today about health information exchange, and hope that this will be a good precursor to your following discussions. So I'll break this up. I'll give you a very high-level overview of health information exchange and how it works specifically in New York State. And then I'll give you sort of the national and overall state context, and then I'll talk to you a little bit about why it's important to both providers and public health. So first, let us define the term health information exchange. It's somewhat confusing. It's both a verb and a noun, and today we're going to focus a lot on the noun aspect of it, but you can hear people referring to health information exchange, which is just that, is exchanging health information between two or more entities. As a noun, it really refers to an organization that brings together healthcare stakeholders within either a defined area or a defined population, and then facilitates the information exchange amongst those people. And some examples of the noun health information exchange would be a regional health information organization, or RIO. That is an organization that wants to facilitate information exchange over a defined geographic area. And there are also private health information exchanges, such as hospitals. For instance, NYU has one, and they seek to exchange information around certain patient populations, not necessarily restricted to a particular geographic area. So those are two examples of health information exchanges. So what does that look like in New York State? So there are 10 RIOs. Remember, that's a regional health information organization. There are 10 RIOs in New York State, and currently we have four in sort of downstate area, really 3 in New York City. The 3 in New York City are the Bronx, Halifax, and Interborough. As you can see from this map, they all cover different separate and distinct geographic areas, which makes a lot of sense when you look at the sort of the northern territory, but when you get down into New York City, you can see how very quickly it's a problem to have 3 if they don't have a means of connecting to each other. So let's talk a little bit about how they're connected. So in the boxes, you'll see these are just hospitals, federally qualified health centers, small practices, even different types of medical providers who use an electronic health record, or an EHR, will connect to a RIO. They have a choice to connect to whatever RIO they want. Some, and frankly, many of them have not yet chosen to connect to a RIO, but as they begin to connect to RIOs, we start to get these clumps of different providers. So many providers, for instance, can connect to RIO 1, which could be Halifax, and others will connect to RIO 2, which could be Interborough. Some may be connected to the private health information exchange at NYU, for instance. And that would be a problem if we left it at that, right? Because that would be in this example, 3 different places to further silo information. But thankfully, New York State has put forward the State Health Information Network of New York, and I'll talk a little bit more about that in a bit. But essentially, that is a public-private partnership, public utility that has as its aspirations the goals to connect all of the different RIOs and to facilitate statewide health information exchange. So that's sort of the large 20,000 foot level picture. Let's get into a little bit about what that really means when you get to the provider level. So imagine a patient goes to a provider who has an electronic medical record, and that electronic medical record is connected to a RIO. The EHR can either send to that RIO either a log, just a notice that the patient was seen. So for instance, hey, Amanda Parsons was seen on this date, that's it. Or it could send an actual summary of the visit, and what it sends is dependent on how it's set up and what the RIO wants to receive versus what the EHR wants to send. But either way, the RIO knows that either Amanda Parsons was just seen, or it knows a little bit more about me because it knows that it's gotten a summary of care visits. So that information is sent to the RIO, and remember the RIO is connected to the Shiny, so that when the patient then goes to see another provider who is connected to a different RIO perhaps, the provider asks the patient, do I have your permission to download information about you that from other settings where you may have gotten care? If the patient consents, and they do that by signing a statewide consent form, allowing that specific provider or that provider network to access the information. The provider then logs the fact that they have a consent. They make it that known to the RIO, and the RIO sort of takes it over from there. So then the RIO will submit a query to the State Health Information Network of New York to say, hey, does anybody have any information on Amanda Parsons? The Shiny will then distribute that query to other RIOs. For the purpose of the example, I kept it simple, but you can imagine this is a distributed query that would grow out to frankly anything the Shiny was connected to. And remember that this first RIO, so in one instance it either just knows that I was seen, or it knows something, it actually has the summary to send back. If it just knows that I was seen but needs the summary of care record, it will call it down from the provider. And all of this happens electronically in a matter of seconds. And then what gets returned back to the original provider is a summary of care document from every place the patient was seen. And so that is sort of a very, very high-level overview of how it works. There are people who spent many, many years pursuing advanced degrees to understand it at much more detailed level, but for today's context, that's what I wanted to share with you. You should know that this, many of you are aware of this, but this is a national trend towards greater use of electronic health records and health information exchange. In 2004, George Bush started the Office of the National Coordinator for Health Information Technology. We affectionately refer to it as ONC. And it was legislated and funded by the HITECH Act, which was the Health Information Technology for Economic and Clinical Health Act. That was part of the stimulus funding to get our economy restarted. The idea there is to have one national coordinator who would oversee the national health IT infrastructure, provide leadership on the development of standards, coordinate a lot of the policies, and do strategic planning for the nation writ large, and to establish governance over a national network. We're not anywhere close to having a national network of Shinies quite yet, but a lot of the groundwork is currently being laid. Just so you understand where ONC sits, it reports directly into the Department of Health and Human Services. And I note that because it's important that all of these government projects work well together. So for instance, CMS and ONC are coordinated in terms of the kinds of data that they're asking providers to send it. That's important because as we tap into the provider networks and say, report these measures, report those measures, if everybody's asking for different sets of measures, that's both confusing to the providers as well as to the vendors who are tasked with actually building these measures. And then ONC really focuses, it's got a health information exchange arm, it's got a policy arm, it's standards arms, and all of this works to basically work on issues of cybersecurity, of innovation. Again, I mentioned the National Health-Wide Network, figuring out how to fund health IT adoption. There's no point in really talking about health information exchange if you don't have electronic medical records in all of these places. So a lot of the work done to advance that nationally is done out of the National Coordinator's Office. So actually, I'll skip this slide in the interest of time. Just to put everything in context, so the HITECH Act funded a number of different initiatives. There were regional extension centers, of which actually the Department of Health has one of them for New York City. Those are centers that were tasked with helping to spur provider adoption of electronic medical records. There was a lot of money that went into workforce training, recognizing the disparity between the types of workers we have and the types of workers we need in order to facilitate health information exchange. There were a lot of penalties and incentives built into Medicaid, the Meaningful Use Program being an example of that, and a lot of work done to advanced standards. Imagine if you're trying to exchange information, if I want to send you a blue letter and you want to get a green envelope, it's very difficult, right? So we've all got to agree on what exactly it is that we're sending, so that it can all work seamlessly together. How this looks in New York State, so the New York State Department of Health has an agreement with an entity called the New York eHealth Collaborative, which is a public-private partnership. The New York eHealth Collaborative is a nonprofit organization, again, as I mentioned, that is tasked with actually ensuring the exchange of information in New York State. There are a number of committees that determine the policies for those, and those, the New York eHealth Collaborative has agreement with what's in the orange box, which are the RIOs, so it helps to ensure that all the RIOs are moving forward in lockstep in terms of the types of services they deliver and the standards that they're using. Know that those are being qualified by an independent certified body, so that not everybody can raise their hand and say, I want to be a RIO. You'll have to meet a certain level of standards, and you'll have to be certified by an independent third party. How is that working? Well, in New York State so far, many hospitals are already connected to RIOs. That's the bar all the way on the left. They are connected. Most of them are contributing data. Some are just accessing data. Federally qualified health centers are also very well connected to RIOs. But then you can see for the smattering of other different types of setting, everybody's still in the early adoption phases, including the small physician practices and other settings, long-term care also being a notable setting that's not yet very well connected. Importantly, about 28% of New Yorkers have consented to one or more providers to allow that provider to get information on there. So as these settings become connected, there will be more information that any one provider would get by accessing RIO information. And its importance to public health and to providers is what I'll leave you with. So many of you have seen the New York State Health Innovation Plan. The New York State Health Department has sort of laid out their goal of achieving the triple aim of better health, better care, and lower costs. And you'll see the weave throughout is this theme of connecting people to their own information, connecting people to each other, and connecting through health information technology. So this is very much in the forefront and recognized as a fundamental pillar to improve the quality of care being delivered in New York State. Why do providers want to connect? So firstly, it gives them information that they don't have access to, so they don't know that the person was in the emergency room, or it's not clear to them what was ordered by other clinicians. So this helps to give them a lens on that care. It also provides them a secure method of sending health information. Many of you who have been in the doctor's offices will be underwhelmed by the level of security that they use to sometimes exchange information. Fax machines being a really good example of that, right? You send something on a fax, who knows who picks it up on the other end. So this provides a secure and robust method for exchanging information. It also allows doctors and other care providers to receive alerts and notifications. So if your patient was admitted to the ER, you can sign up to receive alerts about that. So you might not want to do that for all your patients, but certainly for your patients that are very, very sick that you're very worried about. You can sign up to get these kinds of alerts. Many of the RIOs are starting to build additional care management tools, and so that many different providers who take care of the same patient can actually document in the same place, not just in their own electronic medical record, and there's some great examples of that in New York City. The idea is patients can also, once the information is electronic, patients will also be able to access their information either from the RIO or from the provider or both. And then, with a fundamental adage of you can't manage what you can't measure, this really gets at giving providers, the provider community, frankly, the analytics they need and the horsepower they need to do a better job of becoming aware of all of the issues that face their patients. From a public health perspective, there are a couple things I want to just talk to you about. So the first is, you could imagine a system like this would be very useful for case investigation. So authorized public health officials, instead of running around out there trying to figure out where all the information is, would be able to access sort of single place information about a case that they are investigating. Case reporting could be made more, could be done more easily through RIOs. For instance, RIOs could choose to report notifiable diseases, or at least those that are easily reported through the EHRs, could use the EHRs to report to public health. We've talked a little bit about victim tracking, the ability to use health information organizations to become aware of where a patient might have ended up in the case of a disaster, and to be able to relay that information to concerned loved ones. For syndromic surveillance, RIOs would offer a lens onto a new type of data set that, as you can see, we have not historically used, but could be very valuable. And lastly, it offers a conduit for us to talk with providers to send out critical messages and alerts to them when needed. We can even send out clinical decision support, as we do with our citywide immunization registry, which is an incredibly valuable tool to let providers know when patients are due for what vaccines. So in a nutshell, health information exchanges are an important source of timely data for public health purposes. That concludes my remarks, and I'm happy to take questions.
Thank you, Dr. Parsons. We have a lot of hands, so let me start here.
Thank you very much for that presentation. It was extremely informative. One of the things that I find is that with electronic medical records, a lot of times we don't have a psychiatric history, for example. And when you talk about the RIO, when you get a general consent, is that going to be inclusive of a psychiatric history?
Yes, at this time in New York State, we are not able to partition different types of information. So when a patient gives consent to a provider to download all of their medical records from other settings, it would include all kinds of medical records.
So if I could just chime in. So, we are working actually with Amanda in Southwest Brooklyn on a project that was funded originally by the health department, the state health department, and now by CMS. And the idea of the project is to accomplish the triple aim, as it were, for people who have multiple chronic illnesses, including behavioral illnesses. And so there are several premises. One is that psychiatrists and primary care doctors need to talk to each other, and that is really fundamentally good for patients. We at Maimonides physically co-located a primary care clinic in a state mental health clinic, about 8 or 9 years ago, and sure enough, we found that ER visits dropped by 50%, and admissions by 30%. But you can't go around doing that, and hence has been the real value of what Amanda is talking to you about. So now we have over 50 community-based organizations and one other hospital, and we're hoping to sort of propagate it throughout Brooklyn using RIO information, but because there's so much and it's hard to make it actionable, we've adapted a web-based system based on a best practice model. And so if your patient is in the ER at Woodhull, you get a notice like in real time, so you can do something about it. And there's a lot of patients out there, but the information, it's not a medical record, but it's has a collection of data that everybody agreed on the standards, right? So, and if something goes wrong with a patient, I don't know, we'll bore you all with a lot of the details, but a notice is sent out by a care manager if the patient's consented. And the other underlying premise of this work is that, of course, it takes more than hospital-based medical care to make people healthy, right? And so we're working with a lot of wraparound and social service agencies, including the discharge program at Rikers. And in fact, after this very meeting, we are talking about hopefully figuring out something with another grant to put more of this kind of work in the correctional health system, so that prisoners going in and coming out can be followed in a health home, by people, and which is very cool. So I think So is a web-based system for behavioral health. I'm glad to tell you about it.
Dr. Richardson.
It's a very interesting topic, but actually most EHRs, certainly most EHRs in hospitals and large institutions still have a very strong partitioning between the medical records, psychiatric records. You're talking about, I think, a very innovative pilot program, but that's not actually, unfortunately, or fortunately, how it works in most of the system. Because the first clinical application that was built by the downstate RIOs is starting with NYCLIX, which is now part of HealthX, when NYCLIX merged with LifeX to become HealthX. It's scary that I've actually been following this stuff, but one of the early applications that was built was for emergency department providers. So I've actually been using in my clinical practice health information exchange information for at least the last 4 or 5 years, and I think you can all understand how important it can be when a patient winds up in the emergency department, perhaps unconscious, perhaps without family members, but with enough identification that we know their name for me to be able to tap into this health information exchange and get some information about their clinical background. Or even if I have a patient who is talking to me and says, yes, I was at X hospital last month, they did some tests, I'm not sure, I don't remember, I don't understand, and I can go into this application and see not only that they had a CAT scan and a blood test, but the results of those tests, and really avoid repeating expensive diagnostic workups. And so the potential for health information exchange to improve the care that we can deliver to patients in the clinical setting is very obvious to me, but there have been lots of challenges. I think, though, I want to hold on to the potential, and I think one of the some of the advantages of electronic health records that we've all heard about as these are being pushed out can only be realized if we have a well-structured health information exchange. Otherwise, we have electronic information that's just as siloed as the paper was, and so the ability to include clinical decision support is very important. If we build the systems correctly to collect all of the data of interest, the ability to inform health equity issues, for example, if we get good information on patient race and ethnicity and language preference, our ability to actually look at the care we're providing across populations is just tremendous. I'm very enthusiastic about the department exploring the uses of health information exchange to further public health initiatives, because I've really already started to see the benefits in the clinical arena. There is a lot more I know that you could have said about the architecture and the issues and so on, but I do think we have to commit to building this, and it's really important the decisions we make about what we build and how it's used.
All right, I can see a lot of other hands, and then Dr.
Yeah. In clinical practice, we are many clinicians are happy as a comparison to the RIO of the drug control. Now, in our practice, we can go to the web and know exactly what the patient was taking in a drug control. Do you have any idea how many grocery physicians are complying with that, and what do you expect the compliance with the RIO once it's initiated?
So in answer to your first question, I'm not currently briefed on the percentage of providers who are using the controlled substance PDP. I don't know if anybody has the prescription drug monitoring program.
I was referring to ISPAC.
So I'll have to punch on that question. But on your second question, in terms of the how many providers are compliant, this is really the map so far, but there really hasn't been quite the push to increase it. We think it's going to get north of 50% for the smaller practices within the next couple of years. The statewide goal is to have 75% of all providers who use a certified EHR technology to be connected in the next couple couple of years, so should be most.
I think Dr. Butler.
I don't know if there's an answer to this. But given the extent to which sort of the theory of information exchanges has been out in front of the implementation for a number of years, maybe someone has thought of it, but the number that strikes me in your presentation most dramatically is the 28% of people who consented to some degree of information exchange. And I guess, obviously, there are a lot of providers who aren't in a position yet to ask for consent because they're not into a system, into a RIO of any kind. But what do we need to get to? Does anyone know, in order to make the benefits of all this investment really begin to pay? I mean, if it stops at 50%, have we really accomplished that much? There's an assumption that I think this is going to be easier than maybe it will turn out to be. And I think some of our experience in places like New York, which have taken the Affordable Care Act seriously, we're up to what, 25 or 30% of the potentially eligible people for federal subsidies having signed up after a year's worth of magic publicity. So I'm curious if you have a sense, or anyone else has, an ONC has a sense, whatever, where we'd have to get to on the consent side to begin to really be confident of some of these benefits.
So remember that the consent is just for the downloading of information. So the system becomes valuable as providers get connected, irrespective of whether or not patients actually consent, because data is available in the system. And then but on the flip side, if nobody's giving consent to access that information, then it's not being used. And that is entirely in the provider's decision right now to determine whether or not they want to avail themselves of that information. But as you've heard from Dr. Richardson and other providers, they struggle to get the information when they refer somebody to a mammogram or for a colonoscopy. They struggle to get back test results, and so the whole system doesn't need to be connected. It just, I mean, philosophically yes, but practically speaking, there's just, there are a couple of very poignant use cases. Like, I want to know that my patient has been in the emergency room or in the hospital. I want to know the results of diagnostic images that I've never been privy to before in a timely way. I want to know the results of specialty consults. And if we can get those right, that's the critical mass.
If I could just add to that, I would like to point out that this consent issue is not a national strategy. New York State has taken a very strong position that prospective voluntary written consent is required from patients not in order for the information to be collected by the RIO, but in order for it to be accessed by a provider. So the information, it's sort of built, the information is there, but patients must consent to its use by an individual provider. There are other states that have taken other positions, and there are states, for example, where there are opt-out consent rather than opt-in consent, and that has significantly facilitated the growth of and use of health information exchanges in those other states. So this is a very important question. It's a complex one, and I think there are lots of things to be considered and how we might deal with some sort of ceiling on the consent issue. When it is properly presented to patients, who wouldn't want me as an emergency physician to be able to see their health information if they're in my emergency department? But I think there's a lot of concerns about privacy and so on, and the way it's explained has a lot to do with whether or not patients consent. I will say, though, the potential, again, for public health uses is important. There actually was a paper you're probably familiar with, published by one of my colleagues, that actually demonstrated that using health information exchange data, we could have identified the H1N1 outbreak more quickly than we did with the current syndromic surveillance systems that are being used by the department. So it is a tremendous potential, and I think as we use it better and build it better, that it will be easier to convince people of why the consent is important and in their best interest. But I don't want to get bogged down on that now, because people do have concerns about privacy, and we would not want any kind of.
So Pam, do you still have your last
I do,
question?
I do,
remark?
I do. And I absolutely agree with you, about the privacy issue. But I will say, I was listening, to what you said, Lynn, and it brings up a point that Amanda made, which is that different entities have different criteria for privacy, security, and it seems that the Health and Hospitals Corporation's hospitals have a sort of collectively, or the city, I should say, has a different view on some aspects of privacy and security than do some of the others, and it's a problem. And not to single out the city, it's just, it's been vetted and vetted. Thank God I'm not on one of those committees, because they like going all night. But I do want to say that information about psychiatric information, actually getting it has not been a problem at all. And now we have, of course, our own growing body of our own clinical data, which of course we can use if we have permission. We should talk about it. It's been remarkably, yes.
Please proceed and talk about it. Thank you, Dr. Parsons. I think we've been left with a good idea of the public health importance of health information exchange. So we should now move on to the presentations of proposed resolution to amend Articles 11 and 13 as a health code regarding reportable diseases and conditions in laboratories. This relates directly to the presentation on syndromic surveillance. And we have copies for this for the members of the board, if anyone needs. You already have them. And we have Dr. Bonga, Deputy Commissioner for Disease Control, who will present this.
Great, good morning. As Dr. Bass just mentioned, I'm the Deputy Commissioner that oversees all of our infectious disease programs here at the Health Department. And I'm going to propose to you 10 changes that we are proposing to our surveillance and control programs related to infectious diseases. First, just a little bit of background. As you heard during the syndromic surveillance presentation, we collect data on reportable health conditions. Many of them are, but not all of them, are infectious diseases. The actual list of reportable diseases is maintained by New York State. New York City is required to conduct surveillance, that is, collect data about these conditions. But we also have the authority, under the Board of Health, to collect additional diseases. These lists, of course, periodically need updating. Sometimes the terminology for different infectious diseases or other health conditions evolves. New diseases may emerge. And sometimes monitoring for these diseases is proven to not be particularly useful. So on the notice of intent to amend the health code that we've submitted, we are proposing a few changes to the list of reportable diseases in New York City. First, we want to modify the terminology currently regarding severe acute respiratory syndrome. As many of you know, there was a large outbreak of SARS that occurred globally in 2003, and that was attributed to a coronavirus, a set of viruses which are presumed in the past to be relatively benign. More recently, there has been the emergence of another highly pathogenic coronavirus that is currently termed the Middle East respiratory virus. And so we're proposing to change the terminology regarding reporting from SARS to actually severe or novel coronavirus. So this would give a broader definition of what should be reported to us. We're also proposing to remove Kawasaki syndrome from the list of reportable conditions. As some of you may know, this is a illness characterized by a fever, rash, and various other systemic manifestations that occurs in young children. It's actually been on the list of reportable diseases for over 20 years in New York City, but the etiology is unknown, and there really is no public health intervention associated with this condition. We're also proposing to remove viral or aseptic meningitis from the list of reportable conditions. The etiology for viral or aseptic meningitis is rarely identified. In fact, that's why it gets lumped into this category of viral or aseptic meningitis. There tends to be a large degree of underreporting because most of our reporting, as you'll also hear, comes from laboratories and not providers. But for this condition, because there is no diagnosed infectious etiology, we rely only on reporting from providers, which tends to be fairly limited. There is no defined public health intervention. Just to note, though of course West Nile virus is a viral etiology of meningitis, that will continue to remain reportable. So in other words, we will continue to have diseases for which there is an etiology defined being reported. And then for all of these conditions that I mentioned, including removing Kawasaki syndrome and removing viral or aseptic meningitis, the health code still requires physicians or other reporters to report any time they denote a cluster of more than 3 cases of any condition. So we would still retain the ability to identify and then investigate outbreaks of these conditions. The next amendment we are proposing to the health code involves syndromic surveillance and pharmaceutical sales. That was one of the reasons why we had the detailed presentation before this. As you have seen, it can provide useful and timely information about health conditions in the population. We currently receive reports voluntarily from 2 large pharmaceutical chains. The information that we receive includes about over-the-counter and prescription medications. And this data, as you heard, is de-identified. That is, we cannot use this data to identify individual people. The health code does continue in its current form without any amendment, does authorize us to actually inspect pharmacy records if we are conducting a public health investigation, but it does not explicitly authorize us to collect this information on a systematic and ongoing basis. What we've been doing so far has been between a voluntary agreement between those pharmacies and the health department. This just gives you a quick list of the different data elements that are collected currently through this system. So it includes information about the pharmacy itself, about the items that were sold. OTC refers to over-the-counter medications that are sold, and RX refers to prescription medications. So some data is collected about prescription medications that is not collected about over-the-counter medications. So why do we need to amend the health code? Well, as I mentioned, we currently collect this data on a voluntary basis. So actually in our discussions with pharmacies that provide this data to us have felt that they would like to know that there is a legal responsibility for them to report this. Of course, it provides them with a stronger justification rather than they thought it was a good idea to work with us. It also allows us as the department to potentially expand this system if we desire to do so. The way we have proposed amending the health code is to restrict this, though, to pharmacies that only collect information electronically. That is, we would not impose a regulatory requirement that pharmacies, shift from if they're only a cash-only or paper registry-based system to requiring electronic records. This would only be required for those pharmacies that record sales electronically. And rarely would we even consider requesting this from small independent pharmacies because, as you heard, the advantage to the system is to collect largely geographically representative data, which we wouldn't necessarily get from a neighborhood pharmacy. We also are proposing an amendment to our authority to collect health-related information. Again, this was the reason for the background presentation you heard from Dr. Parsons regarding health information exchanges. These health information exchanges are not currently listed as required reporters for health conditions. And in fact, in our discussion with RIOs, these regional health information organizations, they have specifically requested us to negotiate one-to-one legal agreements with each regional health information organization for them to provide information to us. So similar to what we have with pharmacies, they want voluntary agreements to be negotiated. We think that the health code, however, should be amended to give the department access to information that is currently on the health information exchange. This is for our public health investigations. When we're investigating cases, when we have suspect cases, when we have contacts of communicable diseases or carriers as part of our investigations or our disease surveillance activities. The amendment will also allow us the ability to cover non-reporting providers who have information necessary for disease control investigations. If you look specifically at the language, this refers to conditions wherein a provider, one provider is required to report. We gave an example of a dog bite, but if that dog has also bitten other people and there are other people with information about this, the way the language has been changed in the health code would allow us to be able to collect information about that health condition from other entities as well. Moving on to another amendment that we're proposing. This one involves the exclusion of children who have certain infections from child care settings. As you know, enteric bacterial infections like Salmonella typhi, like Shigella, can be readily transmitted in child care settings. This is because children are not routinely toilet trained, and we know that health hygiene in these settings is often inadequate. The health code currently sets the exclusion criteria as children under 6, so that if you are a child that is 5 years old, and, approaching your 6th birthday, and you are diagnosed with, say, Shigella, you would be required to be excluded from child care until you show evidence that you are no longer infectious. The challenge with this age definition right now is we know that children in New York State and New York City currently start kindergarten at the age of 5. And so we know that children in elementary school are almost always toilet trained. So they are really not in the child care settings that we're really concerned about, where you have children who are diapered and there is a much higher risk of transmission of these infections. So we're proposing to amend the health code to change the age cutoff from under 6 to under 5, which would mean that it currently really would only apply to children in pre-care or daycare settings, not elementary schools. We are also proposing an amendment regarding our authority, or clarification of our authority regarding the isolation of communicable disease cases. So this is not related to children, but related to anyone, children or adults. The health code currently authorizes the Commissioner of Health to isolate individuals with communicable diseases that we are defined as pose an imminent and significant threat to public health. The current language, however, is actually vague about who is responsible for actually isolating that individual patient. It simply says they need to be isolated. It doesn't say who is actually responsible for doing that. We are proposing that we would amend the health code to require that it is the attending physician caring for the patient who is responsible for following up on that order from the commissioner. This is consistent with the state sanitary code, and it's also consistent with the language that we currently have regarding the isolation of patients with infectious tuberculosis. And specifically also the amendment we're proposing clarifies that this applies not only to currently reportable conditions, but it may refer to emerging infections, so new diseases that we haven't thought of, for which we would need to institute isolation. The next set of changes we're proposing involve the data that we collect from laboratories. So you've heard already a presentation about syndromic surveillance, where we collect data from emergency departments and pharmacies and schools. As you know, we also collect data from providers. Healthcare providers are responsible for reporting information. But really, probably the most powerful system we have for infectious disease surveillance is electronic laboratory reporting. This is where clinical laboratories are required to report from that list of reportable conditions. This provides us with specificity. In other words, we know who has the disease. It provides us with timeliness. Laboratories have electronic systems already in place, so it's quite easy for them to report electronically. And completeness. We know that many cases of infectious diseases are not reported by providers, but laboratories, because they're already regulated quite strictly, they're much more compliant with our reporting guidelines. So what we're proposing to do is to expand the list of data elements that are currently reported by laboratories. This is because, as we know, the world has become, there's much more data, there are more ways of getting in touch with people now. So we would like that whenever laboratories actually have this information, so that's important to note, the laboratory has to have the information. If it doesn't have it, it's not required to report it. We're proposing that they provide to us the patient's email and mobile phone number. Currently, they're required to provide the patient's name and their address and other contact information, but this specifically indicates modes of communication that were not envisioned when these health code provisions were originally written. Also the same or similar information for the provider. And then, of course, national provider identification numbers, which also weren't in place at the time that these health code provisions were written. And we're also proposing that pregnancy status, if it's known or probable, be reported to us. And this is important because for some infectious disease conditions, specifically syphilis and hepatitis B infection, it's critically important for us to know the pregnancy status of the patient when managing these diseases. And as I mentioned, these are only required to be reported if the data elements are actually known by the laboratory. Similarly, we're proposing a number of different changes to what the laboratories actually report as far as infectious disease conditions go. The health code, as we've said, mandates the reporting of a positive diagnosis of a disease. So a person is diagnosed with, I gave the example for Salmonella or Shigella, a positive result is required to be reported to us. There are some health conditions, however, where we care about just the occurrence of that laboratory test, the fact that it in fact was ordered and was negative. And there are two specific examples that are already in the health code for which we can show evidence of this: HIV viral load and hemoglobin A1C. We don't define a cutoff for the HIV viral load because we actually want to know if the person has an undetectable HIV viral load. It indicates to us that the person, in most situations, 99% of situations, is taking effective antiretroviral therapy if they previously had an HIV antibody test that was positive. And similarly for hemoglobin A1C, it allows us to understand the range of people with glycemic control as opposed to establishing a cutoff for who is diabetic and who is not. So those are situations already in the health code that allow us to collect data on laboratory results even if they are not positive affirmation of an infectious disease condition or any health condition. So we now have a number of changes related to that. The first is regarding tuberculosis. So currently, the laboratory requirements are that we will collect, laboratories are required to report about any AFB, that's acid-fast bacilli positive biological specimen. That's indicative, though not diagnostic, of tuberculosis. Culture or nucleic acid amplification test, that is a PCR test for Mycobacterium tuberculosis. Any culture or nucleic acid amplification test, even if it's negative, that's associated with an AFP positive specimen. So this is another example where a test that's negative is still reported to us because the presence of acid-fast bacilli is so strongly indicative of tuberculosis. Drug susceptibility tests that are performed on Mycobacterium tuberculosis isolates, and any pathology findings suggestive of tuberculosis. So that is what is currently required in the health code. We're proposing that the health code, however, be amended to expand the number of laboratory tests that are reported to us for TB. We would like to see that there's reporting of positive and negative tuberculosis tests in patients with a prior positive AFP smear or prior positive Mycobacterium tuberculosis test. So what that means is that I, as a patient, go to a healthcare provider, I have a cough, and I cough up a sputum specimen. It is seen as to be AFP positive. I subsequently have tests done either at that health facility or another one, or a different laboratory, and those subsequent tests show that I grow a different type of mycobacterial infection, a non-tuberculous mycobacterial infection. Currently, we have to actually hunt down and try to find those laboratory results. This, however, would require laboratories that know about a prior positive TB test to actually report that data to us. This will greatly expedite our case investigations. For patients with previous positive AFP smear or test for Mycobacterium tuberculosis, as I mentioned, these negative results can help us determine whether a patient can stop treatment. That is, there are situations in which we can tell a patient, you were started empirically on tuberculosis treatment, but you actually do not have tuberculosis, so you can now no longer take those medications. Or in other situations that the patient is no longer infectious, so that we can remove them from restrictions on their movement or transit. Additional laboratory changes we'd like to make involving negative laboratory results include hepatitis B virus infection. Hepatitis B virus, there are many different tests that can be performed. We currently collect data about hepatitis B surface antigen results. A patient who has a positive hepatitis B surface antigen is considered infected with hepatitis B virus. One major use of our data regarding hepatitis B surveillance laboratory data is the prevention of perinatal transmission. That is the transmission of hepatitis B virus infection from a mother to a newborn baby. The department actually currently manages about 1,800 women each year who are pregnant
and are known to be hepatitis B surface antigen positive. We manage those patients to ensure that their newborns receive appropriate preventive treatment for hepatitis B at the time of birth. That includes receiving hepatitis B immune globulin and hepatitis B vaccine. In addition to managing them at birth, however, we also are required to follow them up. Good public health practice is to ensure that those babies actually became immune, or if they didn't become immune and they became infected, to actually make sure that they get appropriate treatment. So to interpret results after the child has been vaccinated and received and been followed for 9 months, we recommend that post-vaccination serology be performed. An infected child, as I mentioned, needs treatment, and a non-immune child needs to be revaccinated. So what is the challenge that we have? Well, we need to amend the health code to help us expedite these investigations and specifically to improve the case management of perinatal hepatitis B. We currently spend about 25% of our, this is regarding our hepatitis B team, about 25% of their staff time actually trying to find providers and obtain the results of this post-vaccination serology. That is, I am Dr. Varma and I have a baby that I managed and I gave them vaccinations, but those post-vaccination serology results are not known and not reported to the health department routinely. So we spend a lot of time trying to get these results from providers. And in fact, in about 40% of the cases, we're unable to obtain those results. So we're actually proposing that the health code be amended to require the reporting of all hepatitis B surface antigen and anti-hepatitis B surface results for persons that are 6 months to 5 years of old. And again, this is to allow us to be able to interpret the post-vaccination serology data so that we can help improve the control of this disease. And not just, I guess, interpret it, but actually make sure that we ensure it on it, receive it completely, which we don't currently get. The last change, hopefully that's enough, to the health code that we're amending is regarding another type of hepatitis virus infection known as hepatitis C virus. Just for some background information, a positive hepatitis C antibody test is currently reported to us, as are positive hepatitis C nucleic acid amplification tests, so PCR results. We know that there are about 146,000 New Yorkers who are currently chronically infected with hepatitis C virus. This virus is a public health problem because it places people at a very high risk of developing cirrhosis and liver cancer. And we actually know nationally now that deaths from hepatitis C virus infection actually exceed HIV. And so the rate of morbidity and mortality from the disease is growing because the peak of infections was about 20 years ago. There now, however, are new treatments that are available that can cure this infection faster, more effectively, and with less toxicity than in the past. So we currently collect data on hepatitis C antibodies, as I reported. We only collect the positive results. A positive result means that a person was previously infected with hepatitis C, and this is considered a screening test to see whether or not you are at risk for chronic infection. We also collect the hepatitis C nucleic acid amplification test, and a positive result means that you are currently infected with the virus, and this is considered a confirmatory test. So anybody who has a positive antibody test is recommended to then have a confirmatory nucleic acid amplification test. But we know from evaluations we have done of people with antibody positive results reported to us that about 27% of patients who have a previous antibody test actually never received that nucleic acid amplification test. So there are a number of providers that don't actually follow through on the recommendation to do complete testing. So we're proposing amendments to health code to improve our ability to understand and to manage this disease in New York City. We want the health code amended to require laboratory reporting of all hepatitis C virus nucleic acid amplification tests, not just those that are positive. We believe that this will help us accurately classify the proportion of New Yorkers who were previously infected, who are now currently infected. That is, the denominator is everybody with an antibody positive result, and the numerator is those with a positive nucleic acid amplification test. We want to be able to identify providers and areas of the city where screening but not confirmatory testing is performed so that we can improve the care and treatment of this disease. By knowing where people are potentially at risk, but knowing that they haven't been fully evaluated, we can then design interventions to help improve their care. And this will also allow us to estimate the proportion of patients that are actually cured annually. As treatment becomes more widely available and hopefully much cheaper, we are trying to accelerate the number of people who actually receive curative treatment. And what we currently do with HIV is we can estimate the proportion of the population that's virally suppressed by using the data on positive and negative nucleic acid amplification tests. We hope to be able to do the same thing for hepatitis C. So those people who previously had persistently positive hepatitis C virus nucleic acid amplification tests that are positive, who eventually have persistently negative results, we can presume that they were in fact cured, and so therefore are no longer at risk of disease complications. So I'll stop right there and open up for questions. Yeah.
Thank you, Dr. Varma, part of this.
We tried to consolidate all of them at one. A number of these we've been holding off on, but.
May I just ask you a question first, since there was a conversation earlier after Dr. Parsons' presentation about privacy and so on. How exactly would you be seeking to use the health information exchange data? Can you just give an example? You gave the example of looking for a dog, maybe.
Yeah, so I think a perfect example would be if we receive a report about a case of an infectious disease. I'll give you a perfect example. We are investigating an outbreak right now of Mycobacterium marinum infections. It's an atypical mycobacterial infection that occurs in people who come into contact with fish or seafood. What we have to do oftentimes is then, when we get a case report, is to actually go out and try to hunt and try to find the provider and get records from that provider, and then maybe find other providers that they went to, because there may be other laboratory tests or clinical information we need to investigate this case. So we spend a tremendous amount of time actually with surveillance staff out in the field, going to offices and visiting people. If we had ability to access the regional health information exchange, you could say, for example, query J. Varma and see what providers I had been to, and then target your search for medical records at those facilities itself. That's just an acute example. I think during routine surveillance work, it would occur only for those for which we collect much more detailed information.
Thank you. So open for other questions.
Thank you. Thank you, Dr. Varma. It's a tremendous amount of excellent work here, so I want to applaud your work and that of your colleagues. I know our responsibility is to consider the public health merit of these proposals, but I wondered if you could also give us a sense of the seamlessness or challenges with which some of these will be implemented. For example, there are a lot of additional requirements on laboratories to report additional information, like the patient's email and mobile phone. Is there going to be a new form that the department will provide? And similarly, with the additional reporting of TB tests, all TB tests on patients who had prior positive tests, I'm just trying to think through the processes of having to look back in records. So could you give us a sense about the implementation challenges and if there are any resource implications that would need to be considered as well? Thank you.
Great. No, thank you for the question and the compliments to the people back here who do the real work. I think we're always sensitive to two major considerations. One is, of course, the workload it imposes on us, but also, and importantly, of course, the workload burden, the regulatory burden we place on the providers that are out there and the labs themselves. Without their collaboration, we would never be able to do this work. So let me address the workload outside first, and then discuss what happens internally. We currently have a system by which we have staff employed that actually keep in regular communication with all of the different laboratories to ensure their compliance with reporting and to make sure that they are using the most up-to-date electronic systems and that we're getting the data in an appropriate way. Again, because laboratories are already so heavily regulated, and because pretty much 100% of them also collect data electronically, we have a very good collaboration with almost all of the laboratories, especially the large volume laboratories, the large volume commercial laboratories. So before we propose these changes, we've actually already discussed this with laboratories who have indicated to us that they don't believe that this imposes a large burden. Of course, there is the comment period that would come up if the board adopts agrees to publish these proposed amendments, and so we'll then see, how much pushback there is. But our sense is that there won't be a lot because they have fairly expeditious systems for doing it, and we have a way to monitor them. The workload internally is something we also have considered a lot. This is not something we could have probably taken on even a few years ago, because our disease reporting systems were much more vertically designed. So for each disease there was a different system where the databases were managed much more mechanically, a lot of manual labor. Over the past several years we've transitioned to a electronic disease management system, a uniform software platform that covers all of our diseases except for HIV. And with that system we're able to deduplicate results a lot better than we were in the past. It is clearly a workload burden, but that has changed over time. We've gotten a little bit more adept at being able to use this data. It gets this whole issue about there's a lot more data out there right now, and we're having to keep up to pace on how we can manage it.
I have a question here on my right, and then,
Thank you. So fascinating to me how powerful this big data can be for public health, so thank you for educating us all on this. I have two questions related to pharmacy data. So one was, if I understood what you said, you're not asking pharmacies to collect more information, but only to share with you what they already have. So that burden to me seems not so huge. The other was a specific question as an example of the TB testing. I think you're asking the pharmacies to report positive and negative antimicrobacterium results on patients who previously had a positive result like an AFB smear. Only in their lab, or are those laboratories able to query, like there are several major lab providers, through HIE to find out? So, you know, if it's just one particular commercial lab, they only have their data.
Yeah.
Or are they able to access, say, oh no, you know, 2 years ago at a different lab, they had a positive, so now I know I have to report the negatives.
Yeah, so for the first question regarding pharmacies, yes, you're correct. We're only expecting pharmacies to send us data that they are already collecting. We're not trying to add or require them to collect new additional pieces of information. And as I mentioned before, we would only restrict this to those that collect data electronically already. And right now, just to also get at the question that Dr. Klinsmann asked about workload burden, we don't really have the workload. We don't really have the staffing to handle, you know, tremendous increases in the volume of data we collect. So we would be quite judicious about when we would use this authority and when we wouldn't. As it relates to laboratories, yes, again, the requirements for laboratories are only when they know this information. So if this is a referral laboratory that only does mycobacterial results and doesn't know prior positive results, we would expect them to follow the guidelines as they're written, but not necessarily hold them in compliance if they didn't know that the patient's prior results were positive.
and I think this, well, we have two more questions. I hope we can limit it to that. We're running a little over. But.
I'm sorry to prolong this, but it was a great presentation, and I know it takes a team effort. So you may have explained this carefully, and I just missed it. But with respect to the isolation of patients, once a very heated topic, and this very board actually, did I hear you say that there's the capacity in these proposed regulation changes to add to the list of diseases for which people could be isolated? And is there going to be some process around that? I'm just reflecting on it.
Yeah, I think I have to refer to the exact languages that we changed. The intent is to allow us to, for example, let's say a new virus X emerges in Asia or sub-Saharan Africa. A person lands on a plane in New York City, ends up in a physician's office, and we need to isolate them. The language is written in such a way to allow us with a declaration to essentially include that on those of isolation, whereas the language, previous interpretation of the language would have been that it was only for those conditions that are explicitly named in the health code.
So.
You know what the language is specifically? I'm going to look for it.
That's okay. I'll look it up. But, all right.
Okay, so the language is that it should be, the commissioner has to have designated that it may pose an imminent and significant threat to the public health.
All right.
So it's a judgment decision by Dr. Gossett.
Okay.
And Dr. Richardson.
Yeah, so I just want to clarify, so the use of health information exchange data would be limited to public health investigations of specific cases, is that right? So this is not really extending syndromic surveillance, for example?
No, not currently. We're not proposing to do that.
Okay, and I guess I'm not entirely clear, speaking
I'll give you an example of what occurs currently. So currently, the most common reason that we have to order the isolation of a patient is when a person has suspected infectious tuberculosis and is deemed unlikely to be able to follow up routinely. So on a fairly recurring basis, I'd have to ask my colleagues for the number of times we do this in a year, we have to issue something called a notice of intent to isolate, or notice of obligation to isolate a patient. So this is an order that is signed. It's under the authority of the commissioner, but it's delegated to our head of our tuberculosis control program, delivered to the attending physician of record, that it is their obligation to isolate the patient. The authority extends, of course, to the healthcare institution that they're working in. So most often what happens is we also have to engage the administrator on call for that hospital to provide them with the legal notification. And then they are required to find a guard or somebody else to make sure the patient is not abscond.
Does this apply only to hospitalized patients?
The language I don't think does, but for all practical intent, I think that is the way it would be used. I'm not sure if that may be something we need to look at in terms of the language, because certainly we wouldn't expect an outpatient physician to hire a private security firm. So.
Yeah, I was thinking that down.
Yeah.
So why not
maybe
make the
something we need.
hospital the recipient of the order as opposed to the attending physician?
I don't know. We'll have to, I guess, look at the language for that. Yeah, it's a very good question. I think we need to review the language for that. I suspect it has to do with trying to identify who the responsible person is, but we will certainly consider that and amend the language for it.
Okay, so with those comments noted, can I have a motion to approve publication of this notice of intent? A motion, a second. Can I ask you to say aye or nay?
Aye.
Thank you. Approved for publication. We'll move on now to one which should be a short discussion. It's a proposal to amend, correct a drafting error and resolution to amend Article 47.
Good morning. My name is Martha Robinson, Associate General Counsel, and I'm here to get your approval for publication of this particular resolution, which would only amend a particular section of Article 47 that the board adopted at its December 10th meeting, which had a misprint instead of the term permittee, which was intended, the term school appears. And we are not going to hold any kind of public hearing, but we have to publish this for public comment.
Move for approval.
Second.
May I have an approval? Yes.
Aye.
Thank you.
Thank you. So we'll move on now to item 7, the proposed resolution to amend Article 141 regarding water tank inspection. Sorry, I didn't have my mic on. Can you hear me? Yes.
Greetings again. You guys. We're just talking about this week. I think I've been before the board like every meeting for the last 2 years. There's always something. And this is one of those, there's always something. So we're coming to the board today with a proposal to amend Article 141 to adjust the requirements for water tank, drinking water tank inspection reporting. Let me just run through. Again, I'm Chris Boyd, Assistant Commissioner for Environmental Sciences and Engineering. I'm joined by Dan Cassidy, Commissioner for Environmental Health. So a little background. We have about 10,000 roof tanks for drinking water in New York City and residential and commercial properties. Building owners are currently required to conduct an annual inspection of the interior and exterior of the tank, sample the water, clean the tanks if it's necessary, repair the tanks if needed. We, as a department, have done around 309 prospective inspections of buildings to verify that they're complying with their annual inspection requirements. About 13% of the buildings that we've identified could not present any record of inspection for the past 5 years. 52% of those that we inspected did not have one or more inspections over the past 5 years. The way the health code reads is that the building owner is required to maintain a record for 5 years. So when we do these prospective inspections, we're looking at a 5-year period of time to see what the compliance rate is over that period. What we know is that water tanks are safe, drinking water is safe, and that there is no indication that there is a public health concern about the water that comes out of drinking water tanks. These are prospective, very conservative measures, and even when we are looking at buildings that have poor inspection compliance rates, we still see good water coming out of the building. Recently, there was a New York Times investigation that found bacteria in several of the tanks that they sampled. Just to reiterate, that the New York Times' sampling strategy is one that we would not normally recommend. Draining, agitating the tank, and sampling the mud at the bottom resulted in some positive samples. There's been no credible evidence that drinking water tanks have been associated with a waterborne illness outbreak. Since 1980, all of the samples that we have collected in buildings over 7 stories have been free of E. coli. And we've never had an outbreak associated with a water tank in recent memory in the department. What our goal here is that the public does have a right to know that tanks are being inspected when they're required to be inspected. And an improperly maintained tank can present a risk. And the proposed amendment would enable the department to gather and post compliance information for all buildings with water tanks online, and would require the proactive submission of the inspection report so that there would be a mechanism for us to receive that data from buildings across the city, verify that there is compliance, and make that transparent to the public so that we can identify that quickly. You guys might remember that we did change the health code to require a public posting in all the buildings so that the tenants of the building know that the water tank inspection is available for review. By getting this proactively, we'll be able to verify that that's been happening, and we'll be able to put it out on the web in a manner that allows for easy access by the public. And with that, we would open ourselves to questions and for introduction.
Excuse me, refresh my memory. Exactly who's authorized to do these inspections? Does the department have a list of authorized people that can inspect?
So the health code has a requirement for who can clean a tank. So someone who puts themselves out as doing business to clean a water tank needs to either be a master licensed plumber, or be working under the supervision of a master licensed plumber, or have a permit from the department.
Chris, there seem to be 2 salient conclusions, as I understood the data you presented. One is that there is widespread non-compliance with the requirement for annual inspections. But second, that doesn't seem to have hurt anybody. So my question is, obviously there are risks associated with water tanks, and obviously we can't totally ignore those, but given those 2 phenomena, have you rethought the notion of whether the inspections need to be annual?
I don't think we need to rethink it. You know, there are lots of things that can happen over the course of a year that are unexpected to a water tank. There can be natural, events, windstorms. There can be structural integrity problems in the tank that emerge that have little or nothing to do with water quality, but ultimately are something that needs to be evaluated. So I think it's not an unreasonable expectation to look at it on an annual basis. The same way a building owner is required to look at peeling paint on an annual basis, window guards on an annual basis, boiler safety, that sort of thing. So I think it's consistent with the way buildings are managed. But I think your characterization of the risk is correct, as well as the non-compliance. I think the goal here fundamentally is that compliance will be best driven by public awareness, by an expectation that a building is doing those evaluations. There's no obvious way that a building resident or occupant can find that information. We really, have every reason to believe that drinking water from tanks is perfectly safe in New York City. We don't want people discouraged through a lack of confidence in them to shy away from drinking water.
I just wonder, given the information we have, whether in terms at least of the water quality related issues, it might make more sense to require, say, an inspection every 5 years and then put some real teeth behind the compliance with that requirement, rather than this notion that putting in yet another incomprehensible sign in the lobby with all the others is going to somehow motivate tenants to enforce on their landlords an inspection process, which, if the tenants are sophisticated, knows is almost certainly not going to produce any difference in the risk of unclean water to them.
So the time frame that's in the health code is current with the time frame that's in the building code. So the building code requires an annual inspection and cleaning. The health code requires an annual inspection and water sample. We don't require an annual cleaning. And the big change will be to move away from the scenario you identified, which is yet one more incomprehensible notice in the lobby that says that you can ask the management for this. And that becomes your enforcement mechanism. The change will be that the enforcement mechanism will be automated. The data will flow to us. We'll be able to verify that it got done. We'll be able to automate a response to buildings that don't come into compliance and make sure that that occurs. And if there is a structural integrity problem, the risk will be, the risk is there. So the only thing the health code change is doing is providing a means for us to increase the rate of compliance, increase transparency, and have buildings report on activity that are required to be by us and the buildings department on an annual basis.
Well, it seems to me there's a little bit of Alphonse and Gaston going on with the buildings department, that they require annual inspections so they don't fall down, and you require annual inspections, but nobody's enforcing either of them. So maybe you ought to talk to them about a more rational system that would, I can say as a resident of a cooperative apartment, that it's a very expensive undertaking for us to comply with this law, and if it's no benefit to it, then that raises serious questions about its relationship to the cost of housing in New York City.
Well, I appreciate the remarks. I can say that we're in very close discussions with the buildings department, so we'll be working at, what we're asking for authorization to do is to write rules for the delivery of this information to the city. We'll work in concert with the buildings department to determine the best way to do that, but we'll take your remarks under advisement.
Wait a minute. All right, how many do I have? We haven't heard.
I think we're all gonna.
Yes, so let's.
I'll defer, in the interest of time.
No, let's ask Dr. Gowden to go first.
Thank you. Thank you for this presentation, Mr. Boyd. So you'd mentioned that the sampling from the Department of Health didn't result in detection of E. coli, but the New York Times article detected bacteria. Was that E. coli or a different, potentially pathological organisms there?
The New York Times article reported, I think, 2 positive samples of E. coli and several of coliform.
I'm sorry, what was the
Several samples of coliform. I don't know the exact number.
It makes me, and you also mentioned that the sampling technique by the New York Times would be recommended by you guys, even though it seems that if there is material at the bottom of the tanks, it has the potential pathologic presence for the people who my question, I guess, it raises the question of whether, how good your data is, looking at the quality of water in the tanks and its connection to possible diarrheal diseases.
So we don't have any data to support that the water that's being delivered to residents in any building in the city consistently doesn't meet water quality requirements. There's no evidence whatsoever. The sampling, the water supply isn't sterile, so you will get biological growth as the water flows and moves through the system, through every water main, through every piece of in-premise plumbing. You've got the potential for particulate, and you've got the potential for biofilm and the ability to grow bacteria and get a positive coliform. There's no necessary relationship between a positive coliform and a risk of disease. So the data that we've got, both from a syndromic surveillance standpoint, both from a direct from the sampling of the water supply and our disease surveillance work, there's no evidence that there's a risk posed by the New York City's water supply to the residents.
May I just come in with a question, and then we'll return to the periodicity of inspections. We had Hurricane Sandy that I think emptied a number of
Yes.
water tanks. Could you just tell us a little bit about the experience with that? That
So-
would be sort of a natural experiment.
Yeah, it was kind of a natural experiment. So during Sandy, we lost power across large parts of the city and some parts of the city that had a high concentration of high-rise buildings with water tanks. Those tanks eventually drained out because the pumps were no longer bringing water to the top of the building. And all of those tanks turned on all at the same time. So sort of a worst-case condition where you've drained out the tank, you've lowered the water below the pipe inlet that would serve the water supply. You turn all those tanks on all at the same time. Water comes rushing in. You get a rate of turbulence that you would not normally see in a functioning water tank. And when we did syndromic surveillance, we didn't see any increase in illness associated with that event. And that was really kind of the largest scale natural experiment we could probably think of to see whether or not there's a relationship between these things and systemic risk.
Let me just add one other sort of example. The majority of tests that we conduct as a health department by which we can claim that we've never sampled water from a water tank that in a building system with a water tank that had E. coli comes following a complaint. And complaints usually happen when there's greater turbulence, when there's sediment that's being delivered interior in a building. And so those two represent really worst case scenarios, and those don't generally pose risks.
Okay, let me return to the other questions. I have Pam, Joe.
Go ahead, John.
Okay, thank you very much. It's funny because I think at the very first meeting I was here was about water tanks, so it's all the way around and still hearing about it. I think I just want to second what Dr. Gladdick said. I think you made a strong argument that there's no health risk associated with water from water tanks. And in fact, it's not that you have no data, there's an association. You have a lot of data that there's no association. So if the hazards are really about structural things, why is this in the health code at all? Why are you have lots of important things to do with your time. Why not let fire buildings handle this, since you looked at it and there's zero, you said no cases. So perhaps we should be considering dropping it from the health code.
And Pam, did you want to add anything?
Maybe there's some middle ground, but I get the sense that maybe you ought to think about it some more and come back to us before you.
Well, I mean, that's of course the prerogative of the board. I would just say to this that many aspects of the health code are prescriptive without known cause. There's lots of prevention in the health code. There's an opportunity to essentially describe by code best practices to help prevent things from happening. We're not here to say that there is zero risk associated with a poorly attended water tank. I think what we're seeing in all likelihood is that water tanks are reasonably well attended in New York City. The absence of compliance on our checks does not always mean that in fact they weren't inspected or cleaned. It could be a failure to record keep. So we would be concerned, to be honest, I think, about dropping the requirement because it does demonstrate to building owners that there is a public health mechanism by which water tanks or the failure to maintain water tanks could pose an unacceptable risk to the public.
But your own data would suggest that you would have the same effect and benefit regulations if the requirement were once every 5 years.
I don't think we could say that the benefit would be the same if the requirement for inspection or cleaning was once every 5 years. I think what we would say is that we don't know exactly what's going on out there with respect to compliance. We don't know whether a building that doesn't have records has in fact cleaned once a year or inspected it once a year. I agree with that from a building and structural integrity perspective. The buildings department annual inspection is a worthwhile piece. I can't say that I think water testing necessarily on an annual basis is absolutely critical. But given the circumstances associated, we don't know what would trigger what would be appropriate moment for water testing if structural integrity were found to be poor on an annual inspection. There's a hole in the canopy. There's an opportunity for vermin to infiltrate. There are birds roosting. Those things can be discovered on an annual inspection, and under those circumstances, there should be a water test.
Well, why don't we write a regulation that says that?
Yeah.
I mean, the building department is going to require an annual inspection of structural integrity anyway, and presumably you do talk to them occasionally, although not daily, the way you talk to pharmacies. Why not you say that if the building department finds a breach of structural integrity that may imperil the safety of the water supply, that there has to be an inspection of the tank for purposes of the cleanliness of the water as well?
I think one of the questions that Dan was raising is what message would it send to the community of building owners or responsible for the water tanks to reduce the intended inspection rate?
I'll tell you what it would do for a small building like one in which I live. We're still required to have an annual inspection of structural integrity. It would save us $15,000 or $20,000 every year for the plumber. And you know, again, when the mayor keeps talking about making housing affordable, this is something that helps make it unaffordable.
And Dr. Klitzman.
So there already is a requirement of annual inspections, and I just want to distinguish, you know, whether we're discussing taking that away, making it less frequent, or doing something else. What you're proposing is to, in some ways, ratchet up the attention on this inspection by requiring an electronic form and making it publicly available, which is a resource question. And I don't hear any, how should I say this? I guess what I would say is I'm concerned in the absence of evidence ratcheting up the requirement. Whether we subsequently decide to change the existing requirement is a different issue, but it's hard when we're trying to promote so many health promotion, disease prevention changes in New York City based on evidence to then be in a position of having to promote something that is going to be for some owners and possibly for the department an additional expenditure of resources in the absence of a public health risk. That's my concern.
Well, I appreciate you pointing out, you're right, this is not changing fundamentally the requirement, it only requires a notification. Building owners routinely provide documentation to various city agencies to demonstrate compliance with all kinds of code, whether it's a permit renewal, whether it's an elevator inspection, or whether it's a boiler inspection. The pathway for providing paperwork is not a difficult one, and we don't think it's particularly onerous on a building owner to do so. I don't think the incremental change that we're proposing here is onerous to buildings. With respect to the cost of buildings, I'm not sure where the $15,000 to $20,000 figure comes from. That certainly comes as a surprise to us, given what we hear from the industry about what they charge for services of a master plumber to inspect.
You know what, Matt, is it inappropriate to offer a motion to table this till our next meeting so we can just have conversation and just understand it. I'd like to do that if it's appropriate.
Well, it sounds as though there is some discussion that needs to go further.
Pardon me?
It is an appropriate motion, I'm being told by the general
Well, unless
counsel.
you, we don't need, unless you would like to offer to do it, we can vote on it. I don't want to be a troublemaker here.
I see.
am hearing the sentiment of my colleagues.
Well, one of the things that I think is from a health promotion perspective, giving confidence to the residents of the city of New York that the water in their high-rise buildings is safe. About close to 3 million people live in high-rise buildings with a water tank, and when you have a major public announcement which questions the integrity of that and the safety of that water, and you get weeks worth of follow-up stories with headlines like "Your water tank's the Gowanus" and things like that, it undermines public health messages around the safety, value, and healthiness of drinking water. And when you undermine confidence in the city's water supply, that has real implications. And this is one very simple way for us to make it transparent, verify that compliance is occurring and the water is safe, and it allows us to move forward in doing aggressive health promotion around the safety, cheapness, and quality of the water that comes down from Catskills. We've got Poland Spring on tap, 24/7, right out of your faucet in New York City. And this is just one little way, without much burden, having someone submit a piece of paper that they would have to generate irregardless of whether or not this passed, is one way for us to be able to present that to the public and no longer have this debate.
And any other comments from the program? So we're now at the point where we need either a motion to approve or for this notice of intent for publication, or a motion to table.
The commissioner can't
Well,
say.
if Pam doesn't want to be a troublemaker, I need to.
All right, so be it. So let me then have a second on that motion. Second from Pam Breyer. And can I then have all in favor, show of hands?
Doctors Flag, Policeman, Breyer, and Foreman.
Do we have any nays? One, two.
Two nays. Now we have a really weird thing to do. I don't know.
Honestly, I'm quite prepared to vote for this, but I want to make sure that we get good answers to our questions.
So
Some
may
form of
I
this.
interject just, so what I would say is that, your voting to publish offers an opportunity for public comment. We take public comment seriously. There'll be an open opportunity for everyone to comment before any board member included or your constituents or Dr. Vladeck, your building. We also will hold a public hearing, and interested parties will let us know. We have an opportunity at that point to make decisions about whether we modify, whether we withdraw, or whether we move forward.
Okay.
And I would add that the comments today will be considered comments and
Okay,
response.
that's fine.
Okay.
Okay, then I'll withdraw my second.
Democracy. So we will now have a motion to approve for publication this notification of intent. Mindful of the comments that have been made here by the board, may I have a second?
Yes.
We have to have the motion first.
Yeah, that's
People make it.
I'll motion to put it,
Yeah.
approval for publication.
And now the second, Pam, any
Yes.
second?
Second.
brings